because you didn't touch the person's spine, you just touched their innominate of their pelvis, right? And boom, it opened up, okay? Now, the cool thing is with sacral torsions is that when you realign it and rotate the sacrum back, then the person's pain's gone immediately, usually in their butt. So you just rotate it back and it goes away in their butt. And then I fixed the mechanical issue going on in their back and it went away. They had a herniated disc. I didn't doubt that. I saw their MRI, but it wasn't causing their pain. They call it the F-bomb method because people drop F-bombs in the clinic because they can't believe their pain, pain's going on a different area of the body type thing. Hey everybody, what's up? Physical therapist Dr. Ryan Whelton coming to you from just outside the getting hot Tampa Bay area. If anybody's ever felt the Florida heat, it's starting, it's May. It gets really hot down here. Anyways, if you're new to follow me, I'm a physical therapist from the Tampa Bay area. I'm an inventor, I'm a teacher. I've come up with methods. I've published a paper called The Root Cause of SI Joint Dysfunction, Root Cause of Plantar Fasciitis, a paper on posterior impingement syndrome, and what else did I do? In my sacral torsion shear, I changed the evaluation method, streamlined it, made it easier for people to understand, and published that and how to treat it, and published that in the Journal of what was Practical Pain Management. I think they changed their name to Med Central, showing great results. So people all over the world have been doing these protocols for years now and getting great results. So they tell me. So today I am talking about my SI joint protocol. Okay, so let's review SI joint dysfunction. SI joint dysfunction is caused by, SI joint dysfunction, in my paper, read my paper on my website, wheltonmethods.com, or in my online courses, mainly in my Rehab Results online course, I talk about my orthopedic protocols like this, but when you put both of your thumbs on their PSIS and just kind of move your thumb back and forth and it'll kind of go on and off the knob, ask the person to extend back or do a prone press up test. And what you will see is one thumb will rise if they have an upslip. So in my paper, I outlined upslip and or outflare causes SI joint dysfunction. Okay, so you'll see an upslip. So slipped up like that. So the person extends back and it slips up. When it's supposed to translate inferiorly, it translates superiorly. Okay, and the reason why is because it's no longer dropping down with the sacrum. It's slipped up like that and then going like that as the person extends back. Okay, so it goes superiorly. So SI joint dysfunction. So what you do is you can go to my YouTube channel, Whelton Methods, or Spotify, or I'm on Apple Podcasts now, and I show in depth these, how to evaluate and treat this. So you pull on their leg, make sure they don't have hip replacement surgery or anything like that. Okay. You pull on their leg, okay, bring that back down, the upslip, and then you'll know it because you have the person stand up, and when they stand up and they extend back, then your thumb no longer translates superiorly on the PSIS, it translates inferiorly on the PSIS, like that, drops down with the sacrum. So so after that, you got to get the upslip first. Okay, you can't do this in reverse, otherwise the person will still have pain. So what you do is you have the person lay on their side, okay, and you go like this and push medial on the ASIS, okay, to gap open the outflare portion of SI joint dysfunction. Okay, so in the chronic SI joint world, I've found that it's upslip and or outflare of the pelvis, okay? But in the chronic world, outflares are the problem. Or almost always there in my patients, okay? So it's very rare, very, very rare that I would ever see just an upslip, okay? So upslip and or outflare. So you gap open the outflares of the pelvis, okay? And when you do that, you are opening up opening up the SI joint. Now, if the person still has an upslip and you're going like this, you're still shearing bone-on-bone pain. Okay, but if you pull down the upslip and gap open the outflare, then you can get the relief that you're looking for. And as I always say, you should screen every patient from thoracic spine into the foot for SI joint dysfunction. Okay, because I have seen thoracic pain. I have seen, and I even colored in the groin, the genital area too. I have seen testicular pain that was ruled out as cauda equina syndrome, and medical doctors ruled it out and ended up being SI joint. How do I know that? I realigned their SI joint, and sometimes you have to hold it open. So I held it open like that, hold medial on the ASIS, put a ball between their knees and standing adduction, and hold it open. And when you do, if the person, you ask them, do they still have the SI joint referred pain chart? And if, anywhere, knees, butt, thigh, groin, calf, whatever. And if they say no, then you just confirm that was SI, right? Because you didn't touch the person's spine, you just touched their innominate of their pelvis, right? And boom, it opened up, okay? Now, remember that in my sacral paper, these people almost always have sacral torsion shear. It's very, very rare that I see somebody without a sacral torsion shear, okay? So in school, they teach you have to evaluate, and it's like, I don't know, manual courses, whatever. You have to evaluate in sitting and in standing and prone and all these different positions. I say you don't need to do that. I published this paper in what was the Journal of Practical Pain Management that shows that basically all you need to know is you have the person if you do the prone press up test, okay, just make sure that the person relaxes their glute, because if you put your thumbs on the ILAs, okay, the bilateral ILAs, and you have them doing prone press up tests, some people will fire their glute, and if they fire their glute, it'll throw their chest off. Okay, so I usually do it in standing. Some people say they can't see it in standing, so you can actually do it in sitting. I showed in my paper. You can do it in sitting, where what you'll see is the left thumb, almost always the left thumb dips in. Okay, which means that the sacrum's twisted that way. Okay, which means you need to strengthen the right piriformis muscle and bring it back. Now, the way that you can test yourself for which side the sacral torsion is on is to actually have the person lie supine and test in a 90-90 test, okay? Test their piriformis strength. And the left, they usually have 5 out of 5 strength, and then the right, it's like 4 minus, 3 plus, something like that. And that shows you why their sacrum is torsioned like this, okay? So you strengthen this side to bring it back, okay? And I show you how to do that in my paper and my online Rehab results course on how to bring back a sacral torsion. And once you do that, okay, and so you just hold it down. So to realign the sacral torsion, you just push, I push down, so inferior, and then like that way towards the greater trochanter, like that, okay? And you push in an angle like that, and you can feel it. It's like molasses going like that, and then realigning, coming back into neutral. Now, sacral torsion pain can cause buttock pain. I cannot stand the diagnosis piriformis syndrome because I'm a Y person. So why does the person have piriformis pain? Well, it's because their sacrum's twisted, or they have sciatica. That can happen too, right? But they're usually, what I find is their sacrum's twisted, and they will take the blade of their hand and they will go like this. Okay. One thing I've done over the years is I've noticed patterns in people and the way that people talk about their injuries, and they will take the blade of their hand and they will trace the side of their sacrum like that. Okay. And where their pain is. And that's a tip off to me that these people have a sacral torsion. Now, the cool thing is with sacral torsions, is that when you realign it and rotate the sacrum back, then the person's pain's gone immediately, usually in their butt. So you just rotate it back and it goes away in their butt, right? So, so that's how you know definitively not only what the diagnosis is, but what was causing the pain, you know? So now, sacral torsions can cause sacral shearing at the base of the spine. Now, none of this you can diagnose correctly on X-ray and MRI, if you ask me. I have seen people with no evidence of sacroiliitis on a MRI, on a X-ray, CT, whatever. And then I have the person extend back, you know, my left thumb goes up or, you know, translates superiorly on the PSIS. Yep, they have an upslip, I pull it back down. I gap open their out flares, and then boom, their pain's gone instantly. And I'm like, no, I was shocked when I did this because I had one patient that brought it in and then brought me the disc so I could see it. So I'm staring right at a CT scan of their SI joints, right? And not only was this guy out, this guy was out like big time. Like it was like that. Like my thumb went like way up, translating superior. It was out like, and I'm like, you can't see it. You cannot see SI joint dysfunction on diagnostic imaging, okay? But you can with your hands, okay? Which is a good thing, is because we all got hands, right? So you can just test it like that. When it comes to SI, when it comes to sacral issues, okay, so they can get sacral torsion, they can get pain in their buttock, okay, because it's twisted and the piriformis attaches there. And then you get sacral shearing pain. Now, sacral shearing pain has shocked me. These people, like SI, can hurt at the base of their spine in sitting, okay? And it's shearing bone pain. It hurts like heck. These people are in a lot of pain, bone pain. I've seen it radiate up their spinous process. I have seen a dull ache across their back. What else have I've seen it radiate down like this. So you can get all kinds of referred pain patterns with this. How do you know that? It's because you just rotate it back. And then you have the patient perform the aggravating motion, like extension or flexion. It's usually extension, but some flexion. And the patient's pain's gone instantly after you just realign things. So that's how you know you'll become an expert on referred pain patterns, because it's pretty easy to see when the person has pain and then they don't have pain. Okay, well, that was caused by that. You know what I'm saying? So anyways, you have to screen for this. I'm telling you, in this clinic where most people have failed everything type clinic, you all day long I see this. And they have the story: physical therapy, chiropractic, injection, surgery, orthopedic surgeon, neurosurgeon, x-ray, MRI, massage, acupuncture, repeat. And I rotate their sacrum back, realign their SI joint, boom, gone. I have 3 patients right now with failed fusion surgeries. And and then I had them out of pain immediately. Surgeon said the surgery was a success, but the person still had pain. And then I fixed the mechanical issue going on in their back, and it went away. They had a herniated disc. I didn't doubt that. I saw their MRI, but it wasn't causing their pain. Okay. Now, okay. So let me tell you. Okay. So this protocol, I can usually get it to work like in my paper with an extraordinarily high success rate. Okay. Like in my paper, I published 12 patients and 100% got better. But there's troubleshooting involved in my SI protocol, okay? So some people try it, it hurts, and then they just, stop or whatever. But if you understand what's happening, then you can modify things for the person and then eventually get to the outcome, okay? So now think about it. If someone's SI joint's out, right? And they have an upslip and out flare, right? And these jagged edges on the bone right here, okay? Just shearing against itself, right? And you lay them on their side. This is the one that gets them, is the side lying abduction and adduction on my SI protocol you can find on my website, wheltonmethods.com, or my online rehab results course. It's on there too. So when they're laying on their side, they're laying on shearing bone pain, okay? And so when they do, let's say their left SI is out, right? And they're doing, let's say, adduction, okay? Or the right SI is out, right? And they're laying on this, let's say the right SI is out, and they're doing abduction. What are you doing? You're just shearing an out of alignment SI. It's just shearing bone pain. So that can be a problem, and then people can get flared up from it, okay? But if you know what to do about it, then it's usually an easy fix. What you do is, I tell them to find a happy place. I say, I don't believe in pain with this rehab. Just makes it take longer and flares the whole thing up. So what you need to do is find a happy place. So just lean forward usually, and why I say lean forward is because it opens it like that, okay? So you have them lean forward like that, and then do the exercises like that, or do the exercises like that. And if forward hurts, I tell them to lean back, okay? Now, occasionally if they cannot find a position, sometimes what I will let them do, but I caution them, is to put their foot in back of this, for adduction, okay, in back of their knee. Now, when that happens, see my pelvis go back like that, and when people start to struggle with the weight portion of it, they can compensate by tilting back. And when you tilt back, then you start to strengthen your hip flexor, not your groin muscle, okay? So I tell people, if you're gonna do that, you need to make sure you stay on your side like that, okay? But you can usually find a place for these people to lay, okay? So it doesn't cause pain. Because if it causes pain, you're just gonna make the whole thing worse, okay? There was only one patient that I can remember that I treated, and this guy could not lay on his side. He couldn't sleep, which is a common issue in these people. Can't sleep, can't roll over in bed because their SIs are out and they're just shearing it. Can't sit for long periods of time, or sit, getting out of a car, getting up in the morning when it's all tight and locked down, out of alignment. Extend back, bend forward. It's brutal. This condition's brutal. But this one guy, he was like, I just can't lay on my side at night. He goes, I can't lay down and do these exercises on my side. And we tried everything, like tilt forward, tilt back, put the leg behind, everything hurt. And I was like, finally, after like 2-3 weeks of trying, I'm like, look, man, I don't even want to do this. But I was like, when you get this condition in our current medical model, judging from what I see here all day long, you're kind of screwed. But if you can do these exercises, you'll see it get easier. You can lay on your side and then eventually open it up and stabilize it. And I hated to do it. I literally crossed my fingers because I didn't want to do it to the guy. And I was like, if you do them, well, we should be able to get there. And he just sucked it up and did it. And in 2 weeks, he was able to lay on his side, no pain. So it started to realign, and he was able to sleep at night for the first time in a long time. So 2-3 weeks, I think it was. So you got to find the position that helps, and you got to learn to troubleshoot SI. So on my YouTube channel, Whelton Methods, I have all of these like in-depth videos, or Spotify now, I have all these in-depth videos on how to diagnose and treat these issues where I go in-depth into it. And then obviously my online rehab results course. I go much more in-depth on that. And you got to learn to troubleshoot these issues, okay? If you're flaring the person up, it's no bueno. You're going to hurt the person, and then they'll quit and blame you. So you can't do that, okay? So anyways, if you want to take my courses, I have my Rehab Results course, which is my orthopedic protocols, how I get exceptional results in the I've failed everything population type thing. I got my in-depth I have all my myofascial methods, which that's my instant pain relief course. And that course is, people love it. They call it the F-bomb method because people drop F-bombs in the clinic because they can't believe their pain, pain's going on a different area of the body type thing. It's like a reflexive pain point. You stimulate here, pain shuts off in a different area of the body, that kind of thing. I mapped it at certain joint angles and angles of pressure people have been using for the better part of a decade now and love it. And then I have my sciatica cervical radiculopathy course, which is a circuit that I identified. And I use that to shut pain off immediately in my patients. And it's pretty simple to use, actually. And then I have my inner circle, my VIP inner circle group. And then I also have my results-based, cash-based business model, where I teach you how to open and run a business like I have here, where you target these chronic pain patients that gave up going to people like me, and bring them in, and then you just use my protocols to help them. So anyways, that's that. Go to wheltonmethods.com and you can take my courses and read my papers, and check back, because I'm changing over where I'm going to start teaching live again. Start teaching on Zoom live. So it'd be pretty cool. Anyways, love you all. Peace out.